Thank you very much. So, talking about surgeons, oncologists, we also have a problem with psychiatrists. So, if anybody is missing his glasses, they are here. Your neighbor. In foreign bodies, up to the swallow, you see here there are many narrowings where they can stick. And usually the first thing I ask the residents to do, make an X-ray and look where it is instead of pushing down at the endoscope. And the underlying esophageal disease that may cause problems, there are mainly strictures. Eosinophilic esophagitis is one of the most important reasons why we see patients with food impaction. Like we have every year we have traditional feast where they eat a lot of bratwurst and they stick in their esophagus, and mostly there are young people with EOE, so be aware of that. Less frequently esophageal cancer, motility disorders, achalasia, and therefore we advocate to ensure a workup after extraction of foreign bodies, and this is an important message to look why there was a food obstruction. So this is a case of a 35-year-old female patient. She has a borderline disorder. She has a history of self-mutilation, cuttings, burnings. She puts everything everywhere. She has a history of several mixed intoxications with especially alcohol. She attempted suicide. She was seen by psychiatrists, but she comes every 2 weeks to our department with new foreign bodies. She sticks it into her belly and she swallows it. I can't count the whole endoscopies because in the meantime we have switched already our systems, and so it's since 2011, and there must be like about 100 endoscopies and 50 since 2017. We have another patient that is the same problem, but I will show you what happened. She has been hospitalized in a psychiatric center for several weeks before. Then she came to our department after she had alcohol excess the previous evening, and she was in psychiatry, but she developed nausea and odynophagia and was then brought to our urgent. So here on this slide you see the razor blades. So this is a typical picture for her. And when you go down, you see that there are some tears, there are some lesions, but the stomach is full, and that's the problem. The stomach is full. You have to have anesthesia. That's one of the most important things, that you can't do it just like that, just look inside and take it out and it's over. So you have to wait until anesthesia has time, and you will go there at 11 o'clock in the evening and do the endoscopy at 3 o'clock in the morning. And so this is a typical picture. You see the blades then after suction that they are there. And how can you remove objects? So for the blades, it wouldn't be a good way to take it just like this out, but you have different forceps, you have snares, you have nets. You can see the different possibilities. Nets are usually quite helpful. We have different retrieval devices for different objects. For the blunt objects, you can take forceps. For the sharp point objects, you can take the latex rubber cap. Long objects usually with vectomy snares, and foot can also be taken out with different devices. So this is a typical way to take out sharp foreign bodies with this rubber hood. I will show you the original MTW rubber hood, which is quite easy to push down the rubber in the stomach. It's inverted when you push it down, and then it goes back in this position in the stomach, and you can take easily small objects out. We have seen by Michael Wallace the retrieval secure cap of Vesco. This is also a possibility. I don't use it for this purpose, but you could use it also for foreign section. When you have a big razor and carpet knives like that, and when she swallows things like that, then or hairpins, long hairpins, then you have a real problem, and you may also see eyebrow epilators in the stomach or tablets. And then the most efficient way to take objects out is probably this overtube. Since we use this overtube, it's much easier, we are much more faster, and it's safer for the patient. You have to get to use a little, but this is a real overtube that allows you to have also insufflation to take out different objects. So this is an example how you can grasp then the knives out of the stomach, or dental pin. You see the pins are swimming in the stomach, and then you grasp them and take it out through the overtube. So it's simple as that, but you have to have it in your emergency equipment. You have to take it with you, and at midnight you should have it already ready. So what are the typical foreign mostly esophageal bolus obstruction, like meat in the elderly, especially when they're in the nursing homes and they don't bite enough, and in children mostly small foreign bodies, coins, in up to 76% of cases. So you can imagine what you will see, and if you look on radiographs, you can look for meat boluses, and in children usually the coins will be detected easily by radiographs. There are ESG guidelines. They are from 2016 already, and they are quite helpful. Some of the most important parts of it. I've shown you already the different types and examples of foreign bodies. Then the most important thing is to know that the radio density is different. So if you have like true foreign bodies, non-food objects, steak bones, you can see it on, but sometimes food boluses, fish or chicken bones, glass, you won't see it. So there is another possibility, maybe not in children. You can have a CT scan done, and then you rise the sensitivity from 90 to 100%, and very high, and it's superior. But anyhow, in the first step, I would propose to do a simple plain radiography and to look for the number and size of the ingested bodies. The other thing is, and the main important message is it emergent? Do we have to take it out in 2 to 6 hours? Or is it urgent within 24 hours? Or is it non-urgent and we can wait like 3 days? So I'll look how the passage is. So batteries are really emergent because diagnostic injury, the esophagus are emergent, and the food bolus in the esophagus, when the patient can't swallow anymore, is also an absolute emergency. And the risk of these emergent foreign body objects is that you can have major complications, as we are discussing today, with perforation, mediastinitis, as I've shown, abscesses, especially with bones, and aortoesophageal fistulas, increasing 14.1 times when the bodies are impacted in the esophagus. So this is extremely important to look for these subjects. Then magnets are urgent. You have bodies more than 5 to 6 centimeters that are also urgent, either in the esophagus or stomach or small bowel. So how do we stay out of trouble? you have to make sure that he has really swallowed something, even if there is a unsure history. Look if there isn't really an object. It sounds easy, but sometimes patients are discharged, and the next day they will come with an abscess or something. So it's important to have an X-ray done, or also for and endoscopy should be done in urgency in patients with sharp objects or batteries that have been swallowed, in symptomatic patients that can't swallow anymore, and if there is a large foreign body more than 5 centimeters, etc. This is all, and I hope you will be safe in the nights and not in the endoscopy room with our psychiatric patients.